So welcome to you all this afternoon, this evening, to our first in our IPS IV Forum webinar series for the autumn and winter. So this is following our successful events that we had earlier this year. So this is our first one, which is about subcutaneous infusion and considerations for patient safety. So introduction. We've got, so meet the team for the IV Forum. We've got Sue Rowlands, who sends her apologies tonight because unfortunately she's been caught up in busy clinical work at work this afternoon. Adrienne is the IV Forum Deputy Coordinator. She also has had to send her apologies. We've got Andrea on the call tonight, Val and myself, and we're IV Forum members. And Andrea and Val are very kindly going to do the questions and answers, and I'm your chair for this evening. And I'd like to say a huge thank you to Ross and Convatec for supporting this event this evening. So the programme, so we'll do the introductions, which I've done, and our speakers are Ross, who is MSL, and which is Medical Scientific Liaison and National Commercial Manager for Convatec. Maya Guerrero, which is she's honorary specialist practitioner for vascular access and IV therapy at Frimley Health NHS Foundation Trust. Jane Hodson, who's lead IV practitioner at Guy's and St Thomas's Trust. We'll take all the questions at the end, and we'll close at 6 o'clock. So our lovely speakers this evening, we've got Maya. Maya is currently the clinical specialist lead for the clinical collaboration team of NHS Supply Chain. Previously, she worked as deputy lead clinical nurse specialist for vascular access and IV therapy and continues to hold an honorary contract at Frimley Park. She's delivered presentations both nationally and internationally, and she's published many articles. And in addition, Maya is a guest blogger for the Australian Alliance and Vascular Access Teaching and Research with, or better known as the Avatar team. So then we have Jane Hodson. Jane is, she's the lead IV practitioner at Guy's and St Thomas's. She set up the IV team in 2008 and the OPAT service the year later. Her team is responsible for obtaining IV access in patients with difficult vascular access. She's also set up the Nurse Lead PIC service in 2017, and she's responsible for standardisation of equipment related to IV therapy. She's always looking forward to introducing products that are benefit to the patients. So thank you both for speaking this evening. So just some housekeeping before we get going. So all attendees are on mute. Please ask your questions in the Q&A function. So that if you look at the bar at the bottom of your screen, there'll be a Q&A, click on there. So you can click on that and you can add your questions in there, and we'll take those questions at the end. We are recording the webinar, and the recording will be available probably early next week, but it will post on the IPS website, and it is in the members section of the IPS website. At the end of the webinar, there'll be a really short survey, which we just ask you to participate on, because we really do like your feedback and ideas for future webinars. And then tomorrow you'll get an automated email, which will provide you a link to download a reflection certificate or to claim your professional development hours for your revalidation. So just say we've got our next webinar on the 2nd of November and future webinars. So what I'll do is at the end of the last presentation and the questions and answers, I'll bob this slide back up, and then you can use that QR code, which can take you straight to the IPS web page, and you can register for any of the other webinars that are coming up. Okay, so what I'm going to do now is hand over to our first speaker. So if I can hand over to Ross, please.
Can you hear me okay?
I can hear you fine.
Yes, Ross, you're fine, thank you.
Cool. Okay. So thank you very much, Carol. Like you said, my name is Ross. I'm the National Commercial Manager for the Neria portfolio across the UK. I am a pharmacist, so although I work in a commercial position, I do place a vast amount of importance on the safety and the care and well-being of both healthcare professionals and patients. Thank you very much to Carol and the IPS for setting up this webinar, and also to Jane and Maya for agreeing to share their expertise and experiences with us. Thank you finally to everyone else for joining the webinar, and I hope you find it useful. So I'm just going to go a little bit into the Neria portfolio, which is what I'm responsible for, and the product development timeline as it is. So in 1990, the first Neria product was launched under the brand name of Contact, and this was a steel needle which is inserted at 90-degree angle, and the steel needle remained in situ for the duration of the infusion. Prior to this, there would have been the butterfly needles used with an additional dressing on top, but this is one of the first subcutaneous infusion sets with integrated adhesive. This was then branded Neria in 2008. Similarly, for Neria Soft was also launched before it was branded as Neria Soft in 1995. And this was the first subcutaneous infusion set to combine a variable angle insertion with the ability to disconnect the line at the site of the infusion. And this is a soft, flexible cannula left in situ as opposed to a steel, which was in the previous. We then launched Neria Multi in 2011, as the name would kind of suggest that it's a multiple needle subcutaneous infusion set, and this can have 2, 3, or 4 heads, and this is used to accommodate fast and high volume infusions of immunoglobulins in the treatment of immune deficiencies. In 2013, Neria Soft 90 was launched with an active needle safety mechanism, and this was introduced to comply with the EU Sharps Directive in 2010 to protect healthcare workers from needle stick injuries. This needle is inserted at 90 degrees and has a soft, flexible cannula as well. Finally, in 2017, there was another launch of, and this time, Neria Guard. And this was a passive safety mechanism which was introduced. And this was to meet the highest requirements for needle safety. So the difference there between the active and the passive is that the active safety device within the Neria Soft 90 requires activation by the user. So in this case, have to push the safety cover over the needle. Whereas the passive safety in the Neria Guard is automatic, and the user doesn't have to do anything to activate the safety side of things. It's the only fully automatic subcutaneous infusion set in the world, and it's actuated at the touch of a button, and there's no visible needle prior, during, or after use. This is just to show what these products have been tested and indicated for, which therapy areas. We believe that this isn't all they could be used for, but this is all they're tested for, so this is all they're licensed for. And the 4 therapy areas are Parkinson's disease, immune deficiencies, thalassemia, and pain management. This is just to look a little bit about the directives and guidelines which which affected our development of our products. So already mentioned the EU Sharps Directive in 2010, and this was adopted to prevent injuries and bloodborne infections to hospital and healthcare workers from sharp objects such as needle stick injuries. It states that if an instrument poses a risk of injury, that you must use a safety product as part of the prevention strategy to protect the healthcare professional. There was also EU Sharps regulations launched in 2014, and this implemented specific control measures to protect employees at risk and required an appropriate response in the event of an incident occurring. Regulations for this apply to all employees and employers of the healthcare sector. Finally, the World Health Organization guidelines in the use of safety engineered syringes for intramuscular, intradermal and subcutaneous injections in healthcare setting in 2016. And this recommended the use of safety engineered injection devices and instructs the government to transition to their exclusive use by 2020. This slide looks a little bit about the implications of needle stick injuries. I'm sure that people are aware, but the number of needle stick injuries is a lot. So more than 3 million needle stick injuries per year worldwide. I won't go into the figures on the bottom left. You can see them there, but if we look at the burdens and the costs, the average needle stick injury costs around £571. But that's just an economic burden. And I think that at times we forget about the human and the clinical burden. So human burden is based on the psychological impact that it can have on the person who sustains the needle stick injury. And then there's the clinical burden, which looks at bloodborne infection transmissions. And you can see there, for every 1,000 needle stick injuries from an infected patient, there's a risk that 300 people will become infected with hepatitis B, 30 with hepatitis C, and 3 with HIV. This is just a list of the references which were used in the previous slide. So if anyone would like to see them, then please let me know. Thank you very much for listening, and I hope you enjoy the rest of the webinar. Thanks, Carol.
Thank you very much, Ross. Thank you for that. That was really interesting, and a real reminder around needle stick injuries and my experience in many years of infection prevention and control is dealing with some of that anxiety and some of those psychological problems with needle stick injuries. So I'd like to invite our next speaker. So Maya, if you'd like to share your screen. And thank you for your comments, Ian.
Thank you, Carol. Can you see my screen now? Can you hear me?
I can see your screen and I can hear you nicely.
Thank you, Carol. Hello, everyone, and thank you for taking time joining this webinar. And thank you, Carol, for that very kind introduction. It's always an honor and a privilege to really be part of the IPS IV forum, especially from the spring one as well. I hope everyone will enjoy this session, and I hope at the end of this session you'll have some useful insights to take back in your individual area of practice. As Carol has mentioned, I am a vascular access specialist practitioner with an honorary contract with Frimley Health. Alongside with that, though, I work as my main job, clinical specialist lead for the NHS supply chain. And I belong to a team of clinical collaboration team with a national role of undertaking quality assurance of products provided to the NHS. And my remit is basically mainly on IV therapy and vascular access devices. Just for a brief disclosure, I am delivering this presentation without any conflict of interest to declare, and there is no intention to promote any of the products that will be identified in this presentation. Just to say, I have not received any honorarium to take part in this webinar. To outline this presentation, discussions will be around the C of the sub-Q, as I call it. And apologies to all the infusion specialists in the audience. But for the benefit of our respected generalists and specialists from other fields, not infusion therapy, it is the aim to give a brief overview, definition or description of what is a subcutaneous infusion, with specific focus on the context as a mode of administration for hydration and some medications. And then we will look at what are the practice guidelines relative to the subcutaneous infusion, specifically the new INS guidelines just been published beginning of this year, and then move on to the why subcutaneous infusion should be considered and recommended as an alternative or alongside an IV therapy, demonstrating its safety, effectiveness, and clinical acceptability. And then last but not least will be the how we as an organization in the NHS supply chain look at and review these products to promote its safety, effectiveness, efficacy, and like I said, clinical acceptability, which I think will be a nice prelude to segue to Jane's story and how she successfully introduced and implemented infusion, safety infusion, subcutaneous infusion in her trust. Okay, just a basic structure of parental route of administration, which simply means we're avoiding the GI tract, whereby best practice would dictate that it should only be utilized when no other route is suitable or available, or when it is actually clinically indicated. And the route choices is dependent on the desired therapeutic effect, and more importantly, the patient's safety and comfort. So here it demonstrates where subcutaneous sits as one of these types of parental route of administration of medication or fluid. So here's just to show you a common location of a subcutaneous infusion and how the catheter has actually been already shown by us, or the cannula is actually sitting in the subcutaneous layer with an example of a safety subcutaneous set, as shown there in the middle with the red arrow. For those with the really meticulous clinical eyes out there, it could be argued that it appears like it is in a 90-degree angle. But that is because the new designs of the devices now, as demonstrated earlier on by Ross, have got this kind of feature. So as we all know, normally the subcutaneous injection would be in a 45-degree angle, as shown there on the left-hand side. So a description of an infusion set from the global medical device nomenclature that we use in supply chain, which main purpose is to provide us as health authorities and regulators, and also the healthcare providers, including manufacturers, with a naming system that can be used to exchange device information and, more importantly, to promote patient safety. So the GMDN actually defines this as a subcutaneous infusion injection or port needle is a sterile, sharp, bevel-edged, hollow, tubular metal instrument intended for therapeutic injection or infusion of medicinal substances directly into the subcutaneous tissue or beneath the skin. And shown with a red arrow at the bottom right in a really small print, intentionally, unfortunately, although best practice dictates and as HSC Sharp's directives mandates, these are still available and seen in practice. Again, stressing it as not best practice recommendation. So a safety subcutaneous infusion set with or without extension on the other hand, as per above photo as examples of these safety devices, in its basic form is a set that includes a safety needle over catheter, which is left in situ once the needle is removed. That small plastic tube is actually the carrier. It's designed to carry the medication into the patient's body via the fatty layer of the tissue underlying the dermis. So subcutaneous infusion sets can be used in multiple purposes. It could be intermittent, continuous, or subcutaneous delivery of fluids or medication. It may or may not include a pre-attached extension tubing, and or may or may not have a self-adhesive dressing as well. So by definition from the Royal Marsden, a subcutaneous infusion is a continuous, intermittent fluid administration into the subcutaneous tissue. and evidence-based approaches, it is also used for hypodermoclysis, which is known to be as a method of infusing fluids as an alternative for IV. HTC for short usually is for maintenance of hydration, and usually those who are unable to take fluid orally, example of those are with swallowing problems like the stroke patients, for example, post-operative patients for correction of mild dehydration if there was any bleeding, or as a supplement for inadequate oral fluid intake. Also used for palliative care settings, so for any malignant partial obstructions of the GI tract, and also for thin, frail, emaciated older patients. This is usually probably most suitable for them, contrary to some misconception amongst staff that they are not. So every so often a patient would come in through the front door in hospital, an intravenous line almost is always like a knee-jerk reaction, when all too often the poor house officer or the senior nurse are believed to come and insert a line on or hunt a shy, fragile vein that seems to escape cannulation all the time. So often in these cases, an HDC or a hypodermoclysis may have been a more appropriate treatment for them. But then again, as everything else, the downside of the HDC is limited only for procedures that are mild dehydrations. You cannot really give them to severe dehydration or shock, so they're not really appropriate for them. And for that matter, in any situation, like people who would require more than 3 liters of fluids over 24 hours, in these circumstances, you can't really use this kind of mode of administration, really. And also for those who require quite a control or monitoring of their fluid intake, for example, heart failure patients or renal failure patients. So another thing is you cannot use all kind of fluids. Sometimes they may have recommended 5% dextrose, but has higher hydrogen ion content on them or concentration. And it is likely those would cause local irritation or inflammation. So anything like that should be given no more than 2 liters over 24 hours, and also no more than 2 mL per minute. A higher strength or volume of that solution is not really recommended for subcutaneous infusion. So as the pandemic, and it's really so for the past 18 months, it continues to impact and put a strain on the hospital resources. We do what we can to provide really support now more than ever. That's why webinars like this, conferences like this are so important for us to participate as clinicians, because we need to be able to network and share practices. We will listen to Jane a little later, find out how she's managed to implement this. We need to talk to each other and undertake further researches and studies to do more analysis and data gathering, and try to have a better understanding on what do these things tell us, and brainstorm as we network and move forward. And that's the only way really for us to be able to improve practice. So the recent COVID-19 pandemic has been shared international experience that we didn't really want, with large number of patients and what used to be unusual circumstances such as prone positioning of device insertion, to which I had my fair share of doing myself. But never before in our careers have we been challenged so greatly. So fortunately, the INS infusion guidelines has come early this year. And this is rightly stated that the experience has reaffirmed the perennial importance of infusion therapy and the parallel value of highly educated and well-resourced specialists are really important to improve practice. But there are always questions we must answer, and there's always data and innovation around. So like I said, the INS infusion guidelines synthesizes specialty knowledge and provides a global focus, really. And it's really good that they have updated that and shared it to us, that we expect for patients and demand of each other. So there are two standards of practice with its recommendation of consideration specific to subcutaneous access and subcutaneous infusion. So it states this as an alternative for IV access as part of the vessel health preservation strategy. The patient is assessed for the appropriateness of the subcutaneous route in relation to one, the prescribed medicine or the solution, the patient's clinical condition, and the presence of adequate subcutaneous tissue. Now, there are around 18 practice recommendations, and I have summed it up into 4 in this figure here, which I believe is just a simple, good representation of these recommendations. So first of all is the administration of fluids, could be isotonic, and that's 0.9% of sodium chloride, or like I mentioned earlier, dextrose sodium chloride solution via a subcutaneous device for treatment of mild dehydration, and if the oral route is not feasible. And they've also said to consider subcutaneous infusion as a mode of administration of medications such as the opioids, non-vesicant drugs, immunoglobulins, and certain antibiotics. That's why we've got to find out when we do that, the pH level of these antibiotics we're going to try to administer. So also for those who have difficulty of absorption of these, they suggested to consider hyaluronidase for continuous subcutaneous infusion for peds and adults, just to facilitate the dispersion and absorption of these medicines. So the next one is the skin and site selection. So we all know it's the largest organ in the body, covering a total surface of area of about 20 square feet. So it is known as the first line of defense of our body, which is, in one simple mind, it protects the body from microbial ingress. And the skin element helps in regulating our body temperature, permit sensation, touch, heat, and cold. So if an emaciated patient we breach that protection or first line of defense, then we're partially losing some of these and evidently don't have the protection it provides, which then subsequently puts the body in a vulnerable, susceptible situation of higher risks of infection. So recommendation is to select areas with intact skin and adequate subcutaneous tissue. And also alongside with that, adherence to the standard aseptic non-touch technique during the subcutaneous access of the device, placement, and infusion. So recommendation is to perform an appropriate and sufficient skin antisepsis prior to the insertion of the subcutaneous access device. Next, at the bottom is device selection. So we recommended is to use a small gauge between 24 to 27 gauge and a shorter length, non-metal with lower lock design for infusion. So a metal winged needle is not recommended for infusion, and that's specifically stated in the document. And then we've also got another device, which is your transparent semi-permeable membrane or TSM dressing over the site to allow for continuous observation and assessment of the insertion site. Last but certainly not the least, is equally important as the others, is assessment and monitoring. So monitor patient and access site regularly, so assess the subcutaneous access site and rotate the site as needed. And I have separated the one on the left bottom side. As for me, I believe this is kind of the most important of all, as it is the patient. There's a patient at the end of this in their journey, really. So we address the following educational topics for the patient. So they're recommending one, discuss with them the signs and symptoms of access site complications and advise them as to how and where to report. And the next is advise them of the activity limitations protecting the subcutaneous access site. Just a further reiteration on patient safety considerations with subcutaneous infusions. When choosing a site, most recommended with most consistent absorption is the abdomen, and then the hips and the buttocks, as you can see there, pointed by the arrow. And other possible infusion sites are the outer thigh and back of the arms. Another safety consideration from choosing a site is regularly rotating the site, avoiding risks such as irritation or infection, hypertrophy, or scar formation. So subcutaneous infusion's effectiveness and benefits, and that would include reduction of stress for the patients, particularly those cognitively impaired, versus using an IV administration really, or IV cannulation. Less pain with insertion and maintenance, less or no concern with thrombosis. Also, it's easier to maintain and easier to resite. Hydration at the end of life is a fundamental issue in quality care now, even internationally or globally. And this mode of administration would allow care continuously, even allowing them to have them care in their own homes. And also, this mode of administration is associated with very minimal side effects. So now we go to the how. As I mentioned, I belong to a clinical team embedded in the procurement world to bridge this invisible line or gap between the clinical and the procurement world. The team have been in place for about 3 years now, after a couple of years of being seconded to the Department of Health, and our key roles within the NHS supply chain contract are shown and simplified in this slide. So summarizing simply what we do, we provide quality assurance, including end user informed specifications of products brought by the NHS, used by clinicians, patients, and carers. And we engage with NHS clinicians and end users to shape the product specifications, contribute to resolutions of product issues around safety. So we get involved with siren calls if there is any product complaints or any MHRAs that's being set out. We also inform procurements and the cross-functional colleagues around product hierarchy or regrouping of the products and product use and its attributes. So these also may lead to data cleansing within the product lots and lines. Essentially, we provide product assurance processes, including hands-on product assessment, and also in order to minimize those quality risks within the procurement world. So how does it apply to subcutaneous infusion? So basically, we have a most recent project that we're working on called Infusion Information for Clinical Choice, or ICC. So basically, this is a document which is an information for all clinicians. And this has been developed to really assist clinicians in the decision-making process when assessing the suitability of a product. We provide clear illustrations and descriptions of the features of the products, and the criteria provided in the form of a product matrix so that you can have a document to look at, and you are then empowered to make your clinical choice of certain products for your clinical setting, dictated by best practice and evidence-based practices. So finally, I hope I'm okay with time, Carol. Acceptability, just to present a few systematic reviews demonstrating clinical acceptability of safety subcutaneous infusion. The first one examining the evidences of use of this for drugs and fluids. They have concluded that subcut route is an effective alternative for rehydration in patients with mild to moderate dehydration, and offers a number of potential advantages. That it also suggests that drug administration is well tolerated with minimal associated side effects identified. Another one with results suggesting that patients' preference over IV therapy, recommending that future drug efficacy and safety studies should also include contemporaneous actual patients' preference, where possible, utilizing appropriate measures. And a brilliant piece of work led by Daphne Brothers on the right side there, suggesting subcutaneous access should be considered alongside IV therapy for hydration in older adults and several medications. Also mentioned in this study that additional benefits in terms of ease of use and cost effectiveness of this mode is also clearly demonstrated there. So I think we can all agree that subcutaneous access should be considered alongside any IV therapy for hydration in older adults and several medications. There are numerous studies out there demonstrating this additional benefits in terms of ease of use, like I said, and cost effectiveness. Inclusion of subcutaneous access in clinical guidelines may also promote uptake of this route. That's a hint for those people who write policies and guidelines to help preserve vessel health of vulnerable patients. Also, it is apparent from all these studies that further high quality research is also needed to inform subcutaneous infusion therapy in a variety of population, especially including pediatrics and palliative care patients. And I guess I'm going to end with saying our NMC code dictates that we practice in line with best available evidence. And these are examples of evidence-based practices with recommendations and guidelines. We can drive our practice and as we move forward in our individual clinical setting. And on that note, I say thank you for listening.
Thank you, Maya. That was an excellent presentation. I have to say you're spot on time. So that was really, really good. But it was really a really informative presentation and really highlighted where that best practice is. I particularly liked your reference to being part of the strategy around vessel health and preservation. And do I notice a VHP poster just behind you?
Yes.
So that's excellent. I love that. Okay, so thank you very much. And what I'll do now is I'll hand over to Jane. So if you could stop sharing your screen, and I'll invite Jane to share her screen, please, and to share her video. Can you share your video as well, Jane? Yeah, we can't see you, Jane, and I can't hear you at the moment. You can see your slides. Your slides have come up. Are you on mute? So at the moment, I still can't hear you, Jane, and I can't see you. At the bottom corner of your screen, there should be your mute.
Can you hear me now, Carol?
I can hear you. Perfect.
Okay.
Can we see you as well? Can you click on your video? Oh, that's perfect.
Okay.
Thank
I
you.
totally lost you for a minute there.
Well, I'm so glad we've got you back because I would like to deliver your presentation. Thank you.
Okay. Can you see?
I can see your slides.
You can see my slides.
You just need to start
Okay.
it.
Okay. Now I can as well.
Perfect.
Thank you, Carol. Sorry about that. Thank you, Maya, for that excellent talk. My talk is very different. Mine is very much about the journey here at Guy's and St Thomas's on introduction of a safety subcutaneous infusion set. If I give you a little background, first of all, as Carol said earlier on in the introduction, the IV team here at Guy's and St Thomas's was established in 2008, initially as a very short-term project to reduce high MRSA bacteremia rates. Now, my personal background is primarily in intensive care. I started my career in neonatal intensive care. I'm an American educated nurse. So I started in neonatal intensive care. I dabbled in adult intensive care. I was on a pediatric IV team many years ago. I did apheresis, but the vast majority of my nursing prior to the IV team was in pediatric intensive care. So coming to the adult world at Guy's and St Thomas was a real eye-opener for me in setting up this team. Initially, we had absolutely no clinical remit. We were purely audit and surveillance and education and training. But one of the very first things that was given to me was the huge project of introducing safety cannulas in the trust. There were 3 consultants, one adult in adults, one A&E consultant, one anesthetic consultant, and one ITU consultant, who had all worked in either North America or Australia and were very, very familiar with safety devices. And we had absolutely none at all. So I came out of pediatric intensive care. I had never seen a ported cannula before. Was totally unused to what was happening here, but given this project, it did take a year. We trialed 3 different types of cannulas. Each cannula was trialed for 3 months. It was very stressful, but was successful. And we did, it just so happened we introduced the BD Nexiva cannula across most of the trust. We did have resistance, shall I say, from anesthetics. So they stayed with the ported cannula in theatres. And then from that point on, then it just developed that I then was responsible in introducing, and as Carol said, standardizing all sorts of devices. So we went to safety butterfly needles, we got safety port needles, we did hypodermic needles, we did filter needles. We had covered pretty much everything, with the exception of insulin syringes and subcutaneous infusion needles. So as I said, that started in 2008. It was talked about the EU directive, and then in 2013, the health and safety sharp instruments in healthcare regulations came into place. And the key part of this guidance was about using safer sharps. And in that those regulations, it states the employer must substitute traditional unprotected medical sharps with a safer sharp where it reasonably practicable to do so. I'm reading this and seeing grammatical errors that are not mine, I must say. The term safer sharp means medical sharps that incorporate features or mechanisms to prevent or minimize the risk of accidental injury. So the legislation was out there. And then, so what happened here was we had a visit. So in March of 2014, the health and safety exec decided to come and see us. They had received information that we were not compliant with the Act. They interviewed me as well as many others. They were here for a number of days. But for myself, I was with them for well over an hour. We talked an awful lot about all our good works in the introduction of safety devices. I did gloss over the not so good, except they did pick up and briefly mention subcutaneous infusion devices. I think, if I recall rightly, I bluffed a bit around that, and also it wasn't in my remit, so I couldn't give good accounting for it. But be that as it may, they were actually focused on that particular visit, were focused on theatres. And at the end of their visit, they were very unhappy. We were very lucky that after their visit, we received a warning. We were not fined, and but were threatened with a return visit, and probably are still waiting for that to happen. But as yet, it hasn't happened. But what was reality? So back then, what was the reality? And this was the reality. Maya also had this picture in her slides, I noticed. And it was a standard butterfly infusion set with a fairly big needle that was stuck into the poor patient. And these are actual IR1's Datix reports from quality. So patient was on subcutaneous fluids, but he had removed the needle. He was doubly incontinent. Therefore, the healthcare assistant was going to wash and change the patient. Unknown to her, that needle was amongst his wet clothes and the sheets. The HCA resulted in receiving a needle stick injury. Another one. While rolling a patient to carry out personal care, a subcut needle that was in situ in the patient's left arm on a syringe driver pierced through her skin and then through my finger. And lastly, I was changing the site of the patient's subcut syringe driver needle. I unintentionally pricked myself with the needle that was originally in the patient as I attempted to wrap the dressing around the needle. But due to there being dim lights, I did not estimate how close to my hand was the needle. So I have quite a inbox and a folder with quite a few of these reports of needle stick injury from staff. And just pointing out also, when you look very closely at that picture at the insertion site, there is quite a red area there. And I noticed in Maya's talk, that really nasty inflammation. I'm thinking that was a baby's back. So these weren't comfortable. They couldn't possibly have been comfortable for the poor patient that had them stuck in. And then for our poor staff who were getting stuck by these needles. So although it wasn't my remit, I felt really, really strongly that our staff shouldn't be at risk of a needle stick injury related to these subcutaneous infusion needles. At that time, I was only aware of one device, and it just happened to be this one. But I really, really struggled to find the right person to approach to do a trial. So I spoke to the palliative care team leader at the time, but he was okay for in the hospital, but he had no connection to the community, and it was just really, really difficult to get anyone involved. By chance, the Convatec rep had come in around this time when I was really focusing on this. We needed a solution. By chance, the Convatec rep had come in to meet with our SSI nurse team leader. And he had left a sample of the Neria guard on my desk. And then subsequently, I was introduced to another device by Smith. So I now had a bit more information, and again, Maya's talk was very useful to me as well, because although I was used to giving subcutaneous medications for specific things, I wasn't at all used to hypodermoclysis, and many of the patients that had these needles in were elderly patients. They often had dementia or were confused, or they were palliative patients who were again in extreme pain. So just a patient group that I really had no idea about. So I continued with my journey, and at the end of the day, the process finally began in 2016, and it was really about, who you know. I did meet one of the palliative care nurses. I actually met her through another role, and then she became part of the palliative care team. And so she was a good connection. And then a new matron was appointed for the palliative care team. And I also knew her from a previous project within cancer services. So I had two good links there that I actually had commonality with. So I met with the matron and her team, and I showed them the various samples that I had. I also, through them, was able to link in with the community palliative care team leader, who actually was a really good, useful person to meet, because she worked at St. Christopher's Hospice as well, where they had already implemented safety devices. So with them, we were able to go ahead and start the trial of the 3 different products that we knew were available and we had. It did again. It's time. Time is what everybody is really short on. So the trial ran in mid 2018, as I said, with the 3 products, and it was the palliative care team, both in the trust and in the community. We also had a small trial in the acute admissions ward. Their sister had contacted me because some of her staff had had needle stick injuries, and she was upset about this. And the same with one of the surgical wards. Again, the sister there had contacted me. And so when we were setting up the trial, I offered them the opportunity to have some participation, which they relished, the opportunity to do that. So we had, each product was used for a month. Free stock was supplied by each of the companies for the duration of the trial. And we did have evaluations completed by both the user and by the patients, their satisfaction with the device. And the key elements around that was ease of use and patient satisfaction. And then at the end of the trial, it was actually the palliative care matron and myself sat down. We looked at all the evaluation forms that we had. We actually looked at each of the devices, and the palliative care matron had me use all 3 of them on her, so that I could definitively say that they were easy to use or otherwise, and thus our decision was made. And the winner was the Convatec Neria Guard. Now, I am very much aware that my talk is much shorter than Maya, but that leaves a lot of time for questions at the end. So this is the Neria Guard. It is very easy to use. It is a very small dressing that is integral to the device. It sits at the insertion site, and of course, as Maya said, it is just a plastic cannula that is left inside the patient. So much more comfortable for the patient. So implementation. So, I mean, it was very much close liaison with the company and with our procurement department. Initially, it wasn't available through supply chains. So we had to go through a different route to get it in to the trust. We also, in our trust, we also have 2 different systems. So on the St. Thomas's side, we have the Omnicell cabinets. I'm not sure if everyone is familiar with those, but they are essentially electronic storage rooms, storage cupboards, and everything is behind locked doors, and you enter the patient details. You take your product or whatever you're going to use, you take it out of the Omnicell. You obviously click what you have decided to take, and that maintains par levels, and materials management will come in and stock them up when it gets to a certain level. So it's a way of ensuring that supply is there, and it's also monitoring how our stores are. On the Guy's site, however, we don't have that at all. So on the Guy's site, there is an individual person on each of the clinical ward areas who is responsible for ordering of supplies. So it's quite challenging and really requires a lot of liaison, both from my perspective, but also from the company's perspective of how we sort all this out. Convatec provided education across the entire trust and came back regularly to provide updates throughout that first year. So that sort of took us towards the end of 2019, and then COVID arrived. So at that point, all training stopped, as it would have done everywhere, I am quite sure. So the challenges of running a product about this, and again, it is really all about who you know. Key stakeholders that buy into a change cannot be overstated. If you just try and enforce a change, you will get resistance wherever you turn. So you've got to find the people who want embrace the change and see the rationale for doing it. As I said earlier, everyone is really busy. This process took 5 years, which is quite shocking, really. Getting evaluation forms for those of you who are in a similar role to me, or have procurement as part of one of your remit. Evaluation forms are a challenge and a half. Trying to get evaluation forms is hugely difficult. We have learned to keep them as simple as possible. They can't ask for an awful lot of information because people won't give it. And the other really key thing that we have found of late is actually designating staff responsible for their collection. Because if you don't have designated people, I mean, when I was preparing for this talk and I was going through emails from years ago, I came across so many saying, have you got the evaluation forms? Have you got the evaluation forms? As I said, for us personally here at GSTT, we weren't going through usual ordering practices, and we had 2 different systems. So it made it really, really confusing for people. We also, in the beginning, had challenges with stock levels. We would run out of 1 length of tubing, we'd get another length of tubing in, then that length of tubing would run out and we'd be, so it was, that was a bit challenging in the beginning. And lack of consistency as well in the beginning with training was a bit of an issue, but we addressed that. We made it very clear in liaising very closely again with Convatec on where all the wards were, what, whether they were on the Guy's site, the Tommy's site, who they needed to liaise with, and we really hashed that out, and every area was covered, which was really great. So it was just a process that we had to run through. And then finally, it was around managing frustrations and expectations, and that wasn't just mine. It was everybody's. For me, I thought the palliative care team would take this and run with it, and they fully expected me to take this and run with it. And so there were frustrations there. As I said, frustrations with training, frustrations with stock, the wards wanting to know when they were going to be seen next. So it was just managing all of that, which took a lot of time and energy. But the outcome is that staff are really, really happy with the ease of use of the Neria Guard. Patient satisfaction is huge. We have had no infections related to subcutaneous infusions since we introduced Neria Guard. And most importantly, we have had no needle stick injuries related to subcutaneous infusion since we implemented, which, you know, that you couldn't ask for a better end to a journey, really. We got there, and it's very, very positive. And so that is actually it from me. Thank you for listening and your attention. And truly, if there are any questions, Carol will take that on next.
Jane, thank you very, very much for that that presentation, and thank you for your honesty. And you know, you've talked about the challenges, and it often is very difficult to implement change. So you've been very honest about how you've done it, and I think that'd be really useful for people. So thank you for sharing that, and that really important bit at the end about patient satisfaction. That's what we come to work for. So
Yeah.
So thank you very much for that. I would invite Maya and Ross and Val and Andrea to bob their cameras back on, and we can start some of the questions and answers. I can see we've had quite a few questions have come in. So I'm going to start and invite Andrea to ask the first question, if we can alternate between Andrea and Val on questions, and hopefully if people pose the questions, we've got an idea of who those questions need to be focused at. And okay, so I'll hand over to Andrea. Thank you.
Thanks, Carol. Well, yes, thank you both. Well, all three of you. That was really informative and very, very, very interesting. And I think, as Carol says, you know, people will be able to take a lot back from these 3 talks. I think I just want to kind of start off a little bit around some of the kind of technical aspects. So maybe initially for you, Ross, there has been a question around its availability now, and I know you've kind of put something in our chat, but just to kind of tell the group, is it now available on NHS supply chain? You know, this kind of Neria Guard.
Yeah. So like Jane said, this all started a while ago, and the responsibility of Neria kind of sat with the wound care team. So there wasn't, I guess, a specific focus on it. Since I started last November, I now have recruited a team of my own who are solely focused on the infusion side of things, and the product's now on NHS supply chain, and we have more than enough stock of all of the different lines, so those stocking issues won't happen again. And also having a dedicated team now who do Neria and nothing else. The issues with the training that were mentioned as well, they will no longer be a question around that, because we have a specific focus on Neria, and that's kind of all we do.
Oh, that's great, Ross. Thank you. I think you can probably answer about 3 questions in one go there. So thank you for that. I'll hand over to Val.
And it's thank you to everyone and to the panelists, and for Carol for hosting the webinar. It's something we don't often talk about, is subcutaneous infusion. So it's actually really refreshing to have this webinar put on, and thank you to Convatec. So my question actually is to Maya, and it's that some staff think that the skin doesn't need to be disinfected prior to inserting the subcutaneous device, because they don't actually disinfect for subcutaneous injections. Where is the guidance and evidence, and also what is your opinion, and maybe also for Jane, so both of you really.
Thank you, Val. Yes, in answer to that question, there's a guideline actually. I don't know, I might have forgotten to indicate that on my talk, but it is on the INS infusion guidelines. It actually states there as part of the 18 recommendations for subcutaneous infusion, standard number 18, and you can find that on page 64, where it actually says standard 18 ANTT. we consider the site as a key site. So when you're inserting any device really into a patient's body, you're breaching the skin. So in comparison to the injection, obviously this subcutaneous infusion is longer than a 5-second injection. So you're going to keep that device into the patient body, and it will be there for sometimes 24 hours. So in actual fact, with the hypodermoclysis, as they called it, when it was first introduced in 1865 by a doctor in Italy, the reason this was stopped in the 1950s is because it was causing infection, and that is because people were not cleaning the skin. At first, it was thought to be an effective treatment for cholera at that time in Italy, but then, like I said, because of that misunderstanding that it is not going to a vein, it's just going subcutaneously, but then again, it's staying longer than just a minute or a second of injection in comparison to your subcutaneous injections. I hope that answers the question.
Yeah, Jane, do you want to contribute to this?
As far as the evidence base, I will go with Maya on that one. We took a stand in our trust many years ago, probably when my team started, and we do expect that skin is cleansed before subcutaneous administration. And as Maya said, this is not short term, and you can see, in that picture, you could already see the redness there. And patients can get really nasty infections, and so it's no different. I mean, no, it's not going into the bloodstream, but it is going into the tissues for continuous delivery of fluid and medications. So that's our stance here at GSTT.
Yeah, Jane, what do you recommend in guys? What do you use? What products do you use to clean the skin?
So depending on what we're doing, so for subcutaneous infusion, I think you know what, you put me on the spot now, Val.
Sorry.
I probably have to check.
Sorry.
They probably use Clinell wipes. We definitely use ChloraPrep, if I can say trade names as well, for intravenous, but yeah, it's probably chlorhexidine wipes, chlorhexidine alcohol wipes. Sorry, Andrea, I saw your grimace there.
Sorry, probably my fault, friends, asking the question. I'm going to hand, on that note, because I've been naughty, I'm going to hand over to Andrea.
Sorry, no, I wasn't. I've got something in my eye, actually, Jane. I wasn't grimacing at you. Yes, actually, I mean, probably one for the three of you, really. And it's a comment that somebody's made, and some of this may be anecdotal, but there's a comment that they seem to think that subcutaneous is not used very often in acute and care home sectors. And I don't know kind of what your experience is of that. Obviously, we may be preaching a little bit to the converted here, for want of a better expression. So I don't know, maybe kind of any of you three, if you want to kind of comment on that, or kind of, say if you find it to the contrary. I'll hand over to any of you to start with.
I think it's, I mean, I can only speak about here, and it, as I said in my talk, I mean, subcutaneous infusion is used for the administration of fluids, and certainly specific medications in specific disease states, that it is subcutaneous. I mean, previously I did apheresis and all our patients were on desferrioxamine, which was subcutaneous infusion. So, so it isn't as used as often as intravenous therapy, but it certainly is used. And again, in palliative care in the community, it is definitely used there. I mean,
Yeah, I agree with Jane. It's not as often as an IV access used in the acute setting, but certainly it's used in palliative. In my short experience of about 7 years in orthopedics, we certainly use them for our dying patients and also in oncology in the palliative care. Having worked in the community IV team as well down here in the southeast, we have introduced the hypodermoclysis as well here in the care home. So yeah, it's not as common. And like I said in my talk, from the systemic reviews I've read, they're actually recommending it to be included in the guidelines as an alternative. Yeah.
Thank you. What about you, Ross? I mean, do you kind of, obviously, you know, with you using the product and promoting the product, I mean, what kind of things are you finding out there in clinical areas, both acute, community and, you know, kind of health and social care sector?
We see the usage in the community is, I'd say, is the largest, but we are seeing that across, you know, a different spectrum of therapy areas. So the main usage is within Parkinson's disease, so that's kind of almost all in the community. But there's definitely quite a few trusts which do use a fair amount of Neria-Guard within the acute. We are still a new team, so we're aware that because there was no focus on this before, that a lot of hospitals are probably not aware of the product. So we're trying to reach out to these hospitals, and actually, you know, listening to Maya and Jane is actually helping me and my team, which I hope are listening, to learn and to find out a bit more about how and where it can be used within the acute trust. But we have spoken to a few other hospitals in the last couple of weeks, and they are using quite a lot within the acute trust, and that was within mainly palliative care and and oncology.
That's really good. And I'm part of the Vessel Health, you know, that Carol and Val and many others are involved in from the IPS, and it's just made me think a little bit about, you know, how we kind of, I don't know, maybe when we talk about the patient assessment, we don't, you know, we kind of do say, you know, look at other alternatives. One of the first thing is, you know, do they need that IV? But maybe it's something that we've not really thought about as much in kind of actually, you know, mentioning it a little bit more directly. And it's just given me a little bit more food for thought, I think, as well. I don't know about Val and so dragging Val and Carol into that conversation there as well.
I think there's
all gone quiet.
No, it doesn't happen often either. I think from my point of view, I think there needs to be an array of different options for people, and not every option is right for everyone. So I think, yes, it needs to be put, and I'm going to say the word arsenal, but I don't mean it like that because it makes it sound, but it is something that actually we do need to consider as part of a treatment. And that probably goes nicely on to the question I'm going to, and it's to all of the panelists. So we've looked at it from the point of view of the practitioner and how we're going to deliver stuff, but actually, what is the patient feedback like? Or in some cases where it's palliative, what is the family feedback with regards to subcutaneous infusions? And that can go to any of you.
I guess I'll just, as I said in my talk, Val, we did get patient input in our evaluation of the product. That was very important, that actually it was beneficial to the patient. And so, yeah, so it was an important factor for us. And I mean, that's something that in anything that I introduce into the trust, that's my overriding thing, is it good for our patients? So that's where I come from with everything that I do.
Yeah, no, thank you. Ross, Is there anything you want to add to that with regards to patients and families?
Well, you know, only working from subcutaneous, I can't really compare it to the other routes. But I would say that particularly within Parkinson's in the community, the kind of the ease of use of the newer subcutaneous devices has really changed the ability of some people to live a life where they're not controlled by kind of healthcare professionals. So a lot of these Parkinson's patients can go a lot longer without seeing a healthcare professional because they can use the device themselves, or their parents, you know, their family members or whoever it is can do it for them. So that's obviously saving the healthcare professionals time, but it's enabling those people to manage their own condition and live their lives without constantly being reminded that they have to have a nursing visit, etc. So that's what I'd say. And from people who use the newer products, if they ever have any issues getting hold of it, we're definitely made aware of straight away, because how much of a difference it really makes to them. But I can't compare that to other you know, therapy routes. So that's my kind of one-sided view, I suppose.
Maya, is there anything you'd like to add?
Yes, well, I mean, it's been a while since I used a subcutaneous infusion, and most of the time that we've used it has, like I said, whilst I was in orthopedics, they were patients who are on their end life, and there isn't that obviously opportunity to ask. I guess I can talk from a point of view of gathering information, particularly for this talk, is those studies that they have conducted and shown that patients actually have preference of subcutaneous over IV, particularly the elderly and the ones who are, I mean, I'm talking about the appropriate patients, such as, you know, with mild dehydration, and also a number of studies about used in children, and the parents have noted that, yes, in their comments on that study.
It's great, thank you. Andrea?
Yes, thank you. There's just been, there was a question, it seems to have gone. I think somebody was asking Ross how long they can stay in for. And it was there and then it's disappeared. But I've just remembered that question, so I thought that kind of going to you. Yeah, it's disappeared, but I'm sure
it's because I answered it by typing, that's all. So it's licensed to be left in place for 72 hours. But I was just trying to explain that you know, we are learning from speaking to quite a lot of healthcare professionals that people are using it off license for a lot longer than 72 hours, especially within palliative care. But from our point of view, it's to be left in place for 72 hours, but it may be better off asking a healthcare professional who would give you maybe their view on how long it can be left in place. That's great. So yeah, Jane, I don't know if you want to come in there. That might be Q Jane.
Q Jane. I don't use the devices myself. In practice, what I would say is we leave a lot of devices, be it a midline, an extended well, subcutaneous. We will leave them in as long as they are working well and there are no signs of infection. Yeah, so there may be an indicative time, but it's a clinical assessment. I would say that because of the soft cannula and the fact that the adhesive and dressing, which is all kind of integrated, is very good on the skin. Yeah. That's why people are able to leave it in for a bit longer potentially. But again, that would have to come down to the clinical judgment of people using it. Thank you for that.
Okay, this is a question. I think this is for Ross, and it's from Grace. Are you aware of any trust that is using subcut fluids in the community that I can reach out to? This is something I would like to introduce in my community service.
You're asking the wrong person, I think. I'd like to know that, but actually, I don't know that.
I can ask our at-home service. I don't know, but I can see what I can find out.
Anna has a hand up.
I had mentioned earlier, whilst I was in the community as an IV lead, we have introduced hypodermoclysis, HTC. So if anybody would like to contact me directly on that, I can put you in touch with the Surrey Community Health.
Fabulous. Thank you, Maya.
That's great, thank you. There's a question now from Carmen. Can someone specify the rate for hydration per hour? And if there's a maximum, I've got my wrong now, maximum amount. Thank you. So I don't know if anybody wants to take that one.
The recommendation from the INS is 2 mils per hour over 24 hours, and it shouldn't be more than 2 liters for 24 hours.
Thank you, that's great. Thank you, Maya.
I've got another question. This one's for Jane. Were there any pushbacks to the increase in costs when you introduced this? And how did you overcome them?
You know, all I can say is I have been incredibly lucky in my years in post, because every single thing I have introduced thus far has cost money, and I've never had any pushback. Patient satisfaction, again, is a huge driver. You can usually, there's usually ways of looking at it to make things cost neutral. So, you know, if you're using a steel needle with an extension tubing, and you're using a dressing and you're changing it every 24 hours or every 12 hours, you know, you do the calculation that if you can leave NeriaGuard in for 3 or 4 days, and you would have used 4 or 5 of the previous item, you know, it's how, I guess it's health economics, and how do you look at it to say, well, actually, you know, it's not really a huge expense. So that is part of it, but I can honestly say I have been extremely lucky, and with a very supportive trust.
Thanks, Jane.
Yeah, and
Andrea?
Yeah, and I was just going to add to that, Jane, with your comments, and I know it was a question, but you'd already answered it. You know, the fact of the matter is, as well as the patient, the staff benefits and the absolutely no needle stick injuries is massive.
Yeah,
isn't it?
yeah. And I'm glad you. I mean, so I think it was calculated from our OC Health department that if a patient had a high-risk needle stick injury, that was £2,000 easily, £2,000 for, you know, all the tests, all the prophylaxis, etc. That didn't include staffing, anything else. So, you know, we would, prior to all the safety devices, we very often, easily 8, 10, you know, high risk needle stick injuries a month. And now you're talking, you know, no, sorry, it was much, 50,000. It was 50,000. So, you know, four staff members off through the process of with a high risk, that, you know, that's £200,000. Well, you know, NeriaGuard or, you know, whatever safety device, it's a huge savings. So yes, thank you for reminding me that that was a very big driver.
Thank you. It's just actually just a few questions as well, back to Ross, actually, just a little bit about the actual product. It's just that you mentioned it about being fully automated, and I just wondered if you perhaps wanted to kind of just say what that means and what some of the benefits are to that side of things, Ross, if you could.
Yeah, so the fully automated essentially means that the device is activated at the press of a button, like I said. So the process of inserting the device is a 3-step process. So you remove the cover on the adhesive, take the safety cap out, and press a button is effectively what it is. So once you press the button, where the fully automated means that the device then does everything for you. So it inserts the needle which puts the soft cannula in place and attaches the adhesive, and then automatically retracts the needle instantaneously back into the device. So once you've pressed the button, you take the device away and everything is in place, and the needle is safe inside the device. So that's effectively what the fully automated means, that you don't have to do anything else apart from press a button. And I think that the benefits of this is, apart from the fact that it's really simple, takes a lot less time. With a kind of an active safe device, if it wasn't fully automated, there's still a risk of needle stick injury if you don't follow the correct process. Whereas with the passive safe devices, it can't be done wrong. So it takes away the risk of user error, which then means that lack of training, etc., is not such a bad problem. And it means that no matter who is inserting the device, that the device is inserted the same. So you get the same level of insertion, whether it's being done by a really experienced healthcare professional or somebody who's at home on their own with their family. So again, that enables patients to kind of be involved in their own care and have more self-care, because it's as simple as pressing a button. So that's what I'd say is the main benefit. And we have a 1-minute video which we've kind of sent to some of the users who actually didn't want any training. They just used the 1-minute video to show themselves how to use it. So I guess that's another benefit as well.
Thank you. That's great. Thanks for that, Ross. Val, I don't know if there's anything else popping up. I've got a hand, Maya. Do you want to? Sorry, did you want to come back on that as well? Sorry.
Yeah, my apologies. I just wanted to stand corrected on what I said earlier on about the 2 mils per hour. It's 2 mils per minute. And that was as an example for the 5% dextrose. I have replied to Carmen directly for her specific question as per the INS guidelines.
That's great. Thank you for that, Maya. Thank you. Val, back to you. I don't know if there's any more questions or comments.
You're on mute, Val.
Sorry, I am. So no, I think that's all the questions that we've got at the moment. I'm conscious of the time, so I'm going to hand over to Carol, but thank you very much to everyone from my point of view anyway.
Yes, thank you from me as well. Thank you for really, really good sessions, and thank you for Convatec for sponsoring, and Carol for chairing, and the speakers for some fabulous sessions. Thank you. And the participants for some really great questions and comments. Thank you.
Yes, I would definitely thank everyone, our attendees for tuning in and asking some really, really sensible questions, to all three of our speakers, and to Convatec for supporting this this webinar, and to the two fabulous question askers. So, and I also just want to say hello to Carmen, because I haven't seen Carmen for many years. I met in Romania. So hi, Carmen. We need to catch up. So what I'm going to do is I'm just going to share my my screen. So I've just noticed Ross has said he's learnt an awful lot tonight. I've learnt an awful lot, and I hope everybody else has. I'm going to share my screen again, and so we can just go through, just have a look at, let me just, oops, let's pick up that last, yeah. So you, oh, I bet you now with our pictures, you can't see that, the QR code. It might not pick up the QR code. But
I'll turn my pictures off. We all turn our pictures off, Carol, yeah?
Okay then, and then the QR code will show. And then if you wanted to register for any of the future events, so 2nd of November, we're looking at the DRIP, which is the device-related infection prevention practices and development of some resources. 9th of December, we've got the community IV and challenges. So we've got somebody speaking from OPAT, and we've got a pharmacist on that webinar. 27th of January, we've got patient-centered VAD management, and we've got a patient actually speaking. And then the 8th of March, again, we've got another DRIP event, looking at how we're implementing resources into practice to improve care. So thank you very much all for joining us, and I'll give you back 2 minutes of your evening, and we look forward to seeing you on the 2nd of November. Don't forget to complete the survey, and thank you very much and good night.
Thank you.
Thank you.
Thank you.
Thank you.
You.
Right, I think I'll go because I think you've probably all seen the QR code. So I'll end the presentation.
Thank you.
Bye-bye.
Thanks, Carol. Thanks, everybody. Bye, everyone.
Night.
Good night. Have a good evening.